Okay, so this issue of diagnostic overshadowing is a known issue. That means that that we kind of attribute everything to the Down syndrome. That if a person is experiencing depression, it's because that's what we expect from people with Down syndrome. Or if they have a behavioral challenge, that's just what we expect from people with Down syndrome. This happens for kind of other intellectual disabilities and stuff as well. But that means that these things are likely to be kind of under-recognized, underdiagnosed. And so I suspect that this is really more reflective of this issue of kind of diagnostic overshadowing and not routinely screening and measuring these things than it is reflective of the actual prevalence of these conditions, because other studies where then they administer scales and like actually kind of ask individual people about their mental health symptoms, we tend to see kind of higher rates. It also highlights the need for better measurement, that there's this quote, it gets kind of tossed around a lot in like the business management world, what gets measured gets managed. And I think basically we don't have good tools to measure anxiety and depression symptoms. We're not going to have the tools that we need to be able to recognize it and treat it. And so we really need to have good tools for measuring these symptoms, because we need those for screening to figure out kind of who needs further assessment. So a screening tool, we want it to kind of capture as many people who might have the condition as possible, so we can follow up with them and assess further who has that diagnosis. It helps to inform treatment, kind of which treatment to use. It can inform whether or not insurance will pay for that, because if there's not a diagnosis, then oftentimes insurance won't cover treatment for it. We need measures for research so that we can study the prevalence. And again, this question of like, is depression and anxiety more common? Is it not more common? We don't know that because we don't have good validated tools for that. It also helps direct how much money should be invested in it from a kind of a research perspective or from kind of public health perspectives. The measurement helps us to understand the causes, because then we can identify who has it and who doesn't, and then compare, like you've kind of seen in these other conditions, where it's more recognizable, that like with alopecia, you can tell who has it, who doesn't have it. It's easier to measure. These things like, that are anxiety and depression are, more difficult to recognize. And so we need tools to do that. And then the measurement helps us then, again, once we can identify who has it and who doesn't, we can do research on treatment, because then we can see who gets better and who doesn't get better, and is the treatment effective. So measurement is really kind of underlying a lot of our kind of science and public health initiatives. So the LEAF study then is really aimed, the primary focus of the LEAF study is trying to improve our measurement and understand our measurement for anxiety and depression in people with mosaic Down syndrome and non-mosaic Down syndrome. So the data I'm going to be showing today comes from 64 children, parents, or self-advocates who have a diagnosis of mosaic Down syndrome. They were recruited primarily through the IMDSA research and retreat weekends over the years, as well as through other Down syndrome organizations, Dr. Jackson Cook's previous participants, and also through the DS Connect registry. So we have slightly more females than males. Ages are between 12 and 45. We asked them just kind of in the background report, did they have they had a previous diagnosis of anxiety and depression? And 16% reported a previous diagnosis of depression, and 23% reported a previous diagnosis of anxiety. So these are pretty high. This is higher than what we would expect in the general population. So the scales that we use, so we used some self-report scales. We used the Glasgow Depression Scale for Learning Disabilities and the Glasgow Anxiety Scale. These are scales that were developed specifically for measuring these symptoms in adults with intellectual disabilities. So the phrasing and the wording is more simplified, more understandable. It's on a 3-point scale, never, sometimes, always, rather than sometimes you get these scales with, very rarely, often, like kind of more nuanced, distinctions between them. So it's got 3-point scales, so it's easier. There are matching kind of parent report scales for these, so that we could get the perspective of the caregivers. A lot of our research that we do on people with intellectual and developmental disabilities, we really focus heavily on caregiver reports. And caregivers provide us great information, but not all caregivers, are as attuned to their loved ones. Sometimes the symptoms are not obvious. These are what we call internalizing disorders. It's how somebody feels, and unless they're verbally expressing it, it can be really hard to tell what a person is feeling. So we think that we really need to ask the person themselves, and give them the opportunity. Sometimes they're not able to, Sometimes they still don't understand the questions and we have to rely on the caregiver report. But we really want to make sure that that self-report is being validated, being tested. We're giving them the opportunity to report on their own symptoms. And then we kind of pulled together with a psychiatric diagnostic interview with a person with mosaic Down syndrome and their parent. That's where we kind of take a deeper dive. And this would be more kind of our kind of clinical gold standard for diagnosing mental health conditions would be a psychiatric diagnostic interview. And so we used the psychiatric assessment schedule for adults with developmental disabilities. Again, this was one that was developed specifically for assessing these symptoms in people with intellectual disabilities, because sometimes the symptoms look a little bit different, and the questions are worded in a way that are a little bit more understandable for people with an intellectual disability. All right, so our results. So for the depression symptom scale, this is using the self-report Glasgow Depression Scale. This is a screening questionnaire. So when I talked before about screening for symptoms, where we want to kind of capture as many people who might have the condition, we found that 52% reported symptoms above the recommended cutoff for that scale to suggest that this person might have depression, or they've got kind of significantly elevated symptoms. And so this does not necessarily reflect the clinical diagnosis. So not 52% had depression, but 52% were reporting elevated depression symptoms.
This was not done during COVID time.
So that is an interesting question. So I don't have this data here, but COVID kind of cut our study in half. We had about 30 people before COVID, 30 people after COVID. We switched to online collection, but over Zoom and online on REDCap. When we just look at the percentage above the cutoff, it's actually the same. It did not significantly shift. And there are a few limitations with drawing conclusions from that. One is that they're not the same people, so we don't know how people changed. And from some other studies where they did look at longitudinal changes, even within Down syndrome, of before the pandemic versus after the pandemic, what you see is that some people really struggled during the pandemic, and some people actually got better, or had enjoyed being quarantined, enjoyed there were fewer demands on them, like task demands and things like that. So for some people it was less stressful, for some people it was more stressful. So I think that gets kind of washed out, I think, in the data when we just look at this group of people before and this group of people after. And certainly just in the conversations with families, I could see that some were happy as a clam to be sitting at home and, not having to, go to work and socialize. But for other people, that was their life, and they lost their jobs, they lost their social connections. So it was really a varied response. That's a good question. So when we look then from the psychiatric interview data, then what we see, so this is pulling together both the person with mosaic Down syndrome and their parent into the kind of diagnostic impression. What we see is that if we use, there's kind of two different common criteria for diagnosing depression. One is the ICD, that is kind of an international diagnostic criteria. The other is the DSM, which is the kind of the US American Psychiatric Association's criteria. So you see DSM more commonly in the US, ICD more commonly kind of, in international studies. So what we see is that about 8 to 9% reported meeting criteria for a depression diagnosis. And if we say, if they had either or, if they had met criteria either for ICD or DSM, then 12% of those that complete. So the numbers here the 6 is not, we have some missing data, but of those that completed it, we see 12% meeting criteria for depression. When we look at the most common depression symptoms then, so this is going back to the Glasgow Depression Scale, but let's just look at what are people endorsing, what are the most prevalent depression symptoms that we're seeing. So this is laid out so you can kind of see the proportion of people here that reported that they never experienced the symptom, and then the kind of teal, the lighter teal, sometimes experienced it, and then the gold always reported always experiencing it. So we can see then, these kind of top symptoms here of what they reported. So it's hard to make decisions. They felt tired, felt worried, kind of eating too much or too little, feeling sad. So these are the next step that I'm going to be doing with this data then is figuring out, okay, well, which of these symptoms are most associated then with a depression diagnosis? Because for some of them, so for example, been eating too much or too little is just a common symptom in people with Down syndrome in general, is that kind of difficulty recognizing when they're full. And, so I hear this a lot from families, regardless of what their depression or mental health status is. So some of these things may legitimately be associated with Down syndrome and not necessarily with depression. So the next step then is to figure out kind of what are the symptoms that are really picking up. That can also help us to reduce the number of items if we don't have to ask 20 items to assess depression. If we can find the ones that are the most predictive of a depression diagnosis, we can do even quicker, and easier depression screening. This is then what the parents reported from, as far as what parents reported seeing in terms of depression symptoms in their loved ones. You can see some of the things. So parents are reporting kind of less in general. There's a lot less in the gold and more in the never. But still, so kind of appearing sad, withdrawing from activities, finding it hard to get a good night's sleep, restlessness. These are the things that are being identified by parents. Now, when we switch to anxiety symptoms, we see a lot more anxiety symptoms that are being reported. So in this study, for self-report, 74 of the individuals with mosaic Down syndrome reported elevated symptoms of anxiety. Again, this is not clinical diagnosis of anxiety, but this is, again, meaningful, worth following up levels of anxiety symptoms. And then when we look at again, diagnostic level, so anxiety is made up of a lot of smaller disorders. And so I've got those listed here, and I'll review them quickly. So agoraphobia is kind of fear of kind of wide open spaces, fear of, kind of going out, being out on a bus, being out in a crowded space, can fall into those. Specific phobias are things like fear of the dark, fear of thunderstorms is a really common one that individuals reported. Dogs, snakes, spiders, injections. There's a whole list of specific phobias. Social phobia then is or social anxiety. Panic disorder is having kind of sudden, out of the blue fear response, and we don't see quite as much of that. Generalized anxiety is just kind of worrying, just chronic worrying. And obsessive compulsive disorder is here. So what we see are, fairly, if we look at the percentages here, these are fairly elevated, especially the specific phobias here are fairly elevated. If we then figure out kind of who has any of these, almost 60% reported meeting criteria for a diagnosable level of anxiety disorders. So anxiety is also really, really common. And talking with individuals and their families, we see a lot are reporting obsessive compulsive tendencies, but aren't necessarily crossing the threshold of disorders. And usually that has to do with really rigid routines, having to do things, 6 o'clock, I have to eat dinner, 7 o'clock, I have to brush my teeth, like very, kind of very rigid routines. Was one of the more common things that people reported, or just asking about their schedule. What are we going to do today? What are we going to do tomorrow? And kind of needing to know everything that was kind of coming next and what was going to happen. And again, these are the most common anxiety symptoms from the perspective of the person with mosaic Down syndrome. So this is really characteristic. So this picks up the Glasgow Anxiety Scale picks up worrying symptoms, specific phobias, and then those kind of physiological reactions, heart rate, difficulty, breathing, feeling sick to their stomach. And really what we see is that the things that are kind of in the top of the scale is really capturing a lot of the kind of worry symptoms, the kind of more cognitive in their head, what they're thinking about, kind of worrying kinds of symptoms. And then less so some of the physical sensations, and a kind of, yeah, again, agoraphobia, kind of specific fears are reported less often. For parents, we see similar pattern where it's a lot of the kind of more cognitive worrying symptoms that they're expressing. So the other thing that we wanted to look at is the relationship with between these mental health outcomes and the percentage of trisomy. So Dr. Jackson Cook's research has shown that a lot of kind of cognitive phenotypes, so kind of IQ is associated with percent of trisomy. Again, that idea of kind of other health outcomes being associated with trisomy. We wanted to know, does mental health show this same pattern? Do we see evidence that there's something specific about the difference in their chromosome 21 that's driving risk for mental health concerns, or is it something else? And so what we see here, so this is I'm kind of skip over a lot of the details. We only saw a very small signal when we look at self-reported fears on the Glasgow Anxiety Scale and the percentage of trisomy in their buccal specimen. So we looked at blood. And so what you see here, so this is the self-report fears. And so this is just a correlation between the percent of trisomy in their buccal tissue and then the symptoms on the Glasgow Anxiety Scale specific fear subscale. So if it was a perfect relationship, you would see this line going from basically one corner, to the next would mean that, like, yes, it's perfectly correlated. As their percent trisomy increases, their fear increases. And so we see that it has a slope, but it's still a relatively small portion of the difference. For parents, we see a similar kind of shape, but it didn't kind of cross over into statistical significance. So if we had a larger sample, it might be significant. Sometimes you have a larger sample and the relationship goes away, so we can't really interpret it too much. But this is suggesting that chromosome 21, and having Down syndrome, kind of having a higher percentage of trisomy may increase the risk of having fears, but this is still very early, and it's also not showing a really strong relationship. So I think we can confidently say it's not accounting for that difference. That there are other factors that are related to that. We don't see that relationship pretty much at all with depression symptoms. So when we look at blood or buccal for self-report or parent-report depression symptoms, we're not seeing that same pattern. Okay, so in summary, the kind of major take-home points is that anxiety and depression symptoms are common in people with mosaic Down syndrome, and so most aren't going to have that diagnosable level, but there still are some elevated symptoms. It could reflect that there's a lot of kind of subsyndromal or subthreshold symptoms where it's elevated but not enough that would warrant the diagnosis. It could reflect that they have another mental health condition. Maybe something else is kind of being picked up by the questionnaire that's not anxiety, or it's not depression, or maybe it's a both. Maybe they've got anxiety that's making some of their depression symptoms get elevated. Or it could reflect an underlying medical condition. So there are medical conditions that can mimic or kind of look like depression, or that can cause depression or anxiety, in and of itself. So things like sleep apnea, hypothyroidism, kind of severe nutritional deficiencies, for example, can, cause all kinds of symptoms. So, as a psychologist, the first thing we do when we have a patient come to us with mental health concerns is we want to know, like, have you been to the doctor? Have you gotten blood work done? We want to make sure that those things are checked and taken care of, because if those things aren't addressed, no amount of mental health treatment is gonna help those. The other thing that I would say that these results kind of highlight is that screening for mental health conditions in people with Down syndrome and people with mosaic Down syndrome is a priority and is important. And recently, actually just this year, the U.S. Preventative Services Task Force recommended routine screening of anxiety and depression of adults and also adolescents in the general population, kind of recognizing, and there's been a lot of talk, in the media about this, the kind of mental health crisis that we're all experiencing after the pandemic, that these things are on the rise. And so, our public health experts are recommending, okay, we need to start screening for these routinely in medical visits to make sure people are getting treated. We need to make sure that people with Down syndrome and mosaic Down syndrome and other intellectual disabilities are included in those screenings. It's not uncommon, from talking with, with colleagues and, who are in kind of general services, that they don't always do the screening with people with intellectual disabilities because they don't know that it's important. Maybe they don't think the scales are valid. And so then they just don't get screened. And so we need to make sure that we've got the tools to do that and that they're getting screened. The Glasgow Anxiety and Depression scales, appear to be valid. We recommend using self-report as much as possible. Collect the data. It's not going to hurt, in most cases, to collect the data. And we should use caregiver reports in conjunction or when self-report is not possible. So some of the next steps for this is to do some more research then on the causes, trying to understand why do we see the rates that we do, to take a deeper dive into the role that chromosome 21 plays in that risk, and look at the role of environmental, differences, especially social differences, social determinants of health, or things like, kind of differences in stress exposure, trauma, bullying, employment opportunities, all the things that, in the general population have been shown to predict anxiety and depression. We need to be looking at those for people with Down syndrome and mosaic Down syndrome as well. How those factors interact with each other. Are people with Down syndrome kind of more sensitive to environmental effects because of their chromosomal difference? So those things may kind of interact with each other. And of course, we need more research on prevention, treatment, access to mental health care, and understanding how people with mosaic Down syndrome are similar or different to people with trisomy 21 or other, like translocation as well. So I'm going to invite you to participate in the LEAF study if you haven't already, and sign up for research appointments tomorrow and Saturday. It's open to individuals with mosaic Down syndrome or Down syndrome. We're now looking at people with Down syndrome too, ages 12 to 45. And then also just a little plug for the DS Connect registry. To sign up for that, make sure that people with mosaic Down syndrome are also included in, in the larger kind of body of research on people with Down syndrome as well. And lastly, just a thank you, as others have said, thank you to the families and self-advocates who have participated, because this would not be possible without you. So thank you. And thank you to my collaborators for the help on this project.